Good evening, everybody. Thank you. That's what we need to hear. We need to hear that you're all excited about being here tonight, all right? This is like our 40th program this year. Yes, our 40th program. Pretty amazing. I mean, I remember once upon a time we only did 12 programs in 1 year. Last year we did 45. This year, when it comes to a total close, we have several more coming. We'll have done 50 programs this year. We're in November. We're going to be finished at 50. Thank you for your applause. Thank you. My name, for those that don't know, my name is Stuart Schlossman. I too have multiple sclerosis. That's how all this began many years ago, and we're not going to talk about that tonight. But if you want to speak with me about that after the program, I'll be more than happy to tell you. And by the way, I said we're doing 40, 50 programs this year. Where am I getting all my energy from? It's my audience, and I want to thank you all for that, all right? You all give me the drive to want to do what I'm doing. You give me the drive to want to be able to come back out and educate everybody about MS. So again, I do thank you for that. We are video recording, like I said, and for the reasons that I stated, I'm not going to go into that again. Tonight, though, I want to get done with me quickly because Dr. Baker's got a lot to speak about tonight. We want to thank Sanofi-Genzyme, please. Everybody give Sanofi-Genzyme appreciation for what they did, for giving us the funding to do tonight's program, and I appreciate that as well. And of course, I appreciate all of you for coming here, and so I'll thank you. Thank you. All right. Dr. Baker's going to speak. He's got a lot to talk about. We're going to hold off on all questions until after his presentation, which is going to be about 2 hours?
Yeah, two and a half.
Right, got it. Okay. Don't worry, he'll be less than that. He'll be a little bit less than that, all right? Maybe an hour and a half, all right? He's got a lot to speak about. After he speaks, though, we're going to come back out, and I'm going to go around the room with a microphone. You will not be video recorded. We are only going to record your voice. And if you do not want somebody to recognize your voice, you live in a great state of Disney. Change it to like Mickey or Minnie. And they'll be happy to hear you, okay? Just change out your voice if you don't want to be heard for who you are. After all of this is done, then we will do the raffle, okay? But again, I want to thank you all for coming, and I want to thank Dr. Baker for coming on out today. So let's give him a round of applause and get started. Thank you.
Hello, everyone. This is wonderful. Thank you. Thank you, Stuart, for having me. Thank you for inviting me. This is a unique opportunity for me to be able to talk to you about an extremely important topic in your MS care, and that's learning how and developing your skills for effectively communicating with your healthcare team, your healthcare providers. So just as means of an introduction and agenda, we'll go through some of our objectives tonight. So we're going to talk about what communication is. Simple question, but very, very complex answer. What are some obstacles to communication? And specifically looking at the challenges that are there for us when we're dealing with multiple sclerosis and communicating our needs, wants, desires, our symptoms to our MS healthcare team. And then who or what comprises that team? Who are the team members that are there to help us through this MS journey? And then I'll focus in on some very practical points for improving your communication with your healthcare team. And then we'll look at some other methods of communication that you may not think of. So I just want to tell you that my daughter, Maya, is very good at computers, and so she helped me put this presentation together. Did we get? I gave you the green one, right? Yeah. This might not be the right presentation here. That looks like a giraffe, doesn't it? All right. So there's some. This might be her 7th grade science project. That's the only one on there. No, maybe we'll just work on it. Here. Go ahead and put that back up. We'll see if we can work with this a little bit. Yeah. All right. So let's go on. Yeah. So we're here at Giraffe Facts. Yeah. Giraffes are the tallest mammal, and I think even the newborns are taller than the average human adult, over 6 feet tall. They have a very odd sleep cycle. Apparently, they're one of the shortest ever, between 2 hours and 10 minutes. So from 10 minutes to 2 hours a day, that sounds like my sleep cycle, right? As a doctor, that's how much sleep I get, 10 minutes, maybe 2 hours. Maybe some people with MS have a similar sleep cycle. Your bladder's waking you up, your legs spasm, etc. Oh, no two giraffes have the same spot pattern. Oh, that's like MS, right? No two patients have the same disease course. You've heard MS is like a snowflake. No two are alike. Nobody's course is the same. So I guess giraffes have a similar theme there too. I didn't know that. Did anybody know that? A group of giraffes is called a tower of giraffes. Thanks, Maya, for making this presentation. Giraffe is the only species or vertebrate species that can't yawn. Are you guys yawning yet with these giraffe facts out there? I did know this as a neurologist. Giraffes have specialized brain circulation to keep pressure regulated with changes in position. Makes sense. So if they raise their head quickly, they have special valves in their neck that keep the blood flow from draining down, and otherwise they'd faint, which I've been known to do under bright lights at weddings. It's happened 3 times, a little fact about me. And you can imagine if they put their head down quickly, all the blood would rush to their head and their brain pressure would go up. And if you look at their legs, they have these this thick skin around their legs which compress the blood vessels, kind of like those Ted hose stockings that you have to wear that kind of keep you from getting blood clots and improving your circulation. Oh, maybe this makes sense. So giraffes make no sound. Not because they can't make sounds, but because they choose not to. They make some very subtle coughs or snorts, but they are able to communicate with each other everything that they need without making a sound. So think about what we do on a day-to-day basis and your communication with your healthcare provider, with your doctor. So sometimes you don't have to really say anything to communicate. So what is communication? I'll read some definitions. I'm just going to read them to you. The act or process of using words, sounds, signs, or behaviors to express information or to express your ideas, thoughts, feelings, etc. to someone else. That's the Merriam-Webster definition. I like this one, a means of connection between people. That's communication. Or places. You can imagine there could be communication between New York and Los Angeles via some sort of wiring system or telecommunication or fiber optics or satellite. Any act by which one person gives to or receives from another information about that person's needs, desires, perception, knowledge, or affective states. Communication may be intentional or unintentional, may involve conventional or unconventional signals. I'm thinking about the guy who gave me an unconventional signal when I cut him off today in traffic coming here. May take linguistic or non-linguistic forms and may occur through spoken or other modes. And that's a Joint Commission of Healthcare back in 1992. Communication is very important in healthcare. And they have committees of people that study this and talk about how we should communicate with our patients and how patients should communicate with us. But I like this one. What is communication? It's connection. Communication is connection and it's caring. If you don't care about somebody, you don't really have any desire to communicate with them. And your healthcare provider needs to care about you in order to communicate, and you have to care about them too, and you have to care about yourself in order to communicate those needs, wants, desires. So this is a very simple model of communication, right? We have a sender, and then there's this message here, whatever it might be, and then someone receives that. So in the interaction with your doctor, who's the sender really? Is it you or the doctor? Could be both. I was taught in medical school that the average time it takes after a doctor says, "Hi, what brings you here to the clinic today?" The average time it takes for that doctor to interrupt you is 30 seconds. So we just can't wait. We want to get more information. So if we can just slow down and pause and get the story, I think that. So next time you're with your doctor, see how long it takes them to, after they ask you, what brings you here? What can I do for you? What's bothering you the most? See how long it takes them to interject. So we have to hear the information from you, which is usually in non-medical terms. And it doesn't fit our nice algorithm or a pattern or the way that we think as physicians. But we have to hear this in non-medical terms, and we get this message, and then we have to synthesize all that information and put it into some sort of medical reasoning. And then we have to shoot it back at you and come up with some sort of diagnosis or some sort of plan or some sort of interpretation of the symptoms that you give us. And usually we give this back to you in doctor talk, in fancy doctor talk, and maybe you don't quite understand what we're saying, so there might be a barrier there. So the language is different between patient and healthcare provider. Now, what's the other thing that the doctors do is that when you tell them something, we always repeat it back to you as a fact or as a statistic. So you might say, Doc, I'm feeling, with my MS, I'm feeling kind of down and depressed and sad and melancholy. And our initial reaction, our comfort zone is, well, depression is very common in MS patients, anxiety too, and it affects about 40% of people with MS at any given time. So we spit back a number and a percentage. Does that sound familiar to you guys? But what do you want to hear back? You want to hear something that we heard you and that we've understand and it's registered and it's meaningful to us and we're going to take action on that. So as doctors, we need to do a good job at learning to hear, listen, and communicate back. So why is communication important? And this is how giraffes communicate. So they have this necking behavior, and they touch and they blink their eyes at each other because they don't want to make a sound, because what does sound do out on the safari in the plains of Africa? Sound alerts your predators that you're there. And so they don't want to let the predator know that they've been spotted, so they are able to give messages through these nonverbal communications. They're able to talk to their young through certain body signals. So I'm not suggesting that you do this with your doctor, but it's just as an example of how important communication is for the survival of giraffes, but it's also important for you to communicate in order to survive. In the medical environment, in the medical safari, Serengeti plains, communication is a necessity for survival, because if you don't communicate, sometimes it can mean the difference between life and death. And I'm not being dramatic here. So imagine that if your doctor gives you a prescription for a medication, and it might be, say you're normally on 10 milligrams, and you get home and the pill looks a little bit different. And the doctor's given this prescription, it's gone to the pharmacy tech's filled it, the pharmacist checked off on it, they've given it to you, you've gone home, and the pill looks a little bit different. All you would need to do would be to pick up the phone and communicate and call and say, either to your pharmacist or to your doctor, and say, hey, my pill's a little bit different. It says 100 instead of 10 on it. Is this right? So that's a form of communication. Without that communication, you might take that medication and it's 10 times a regular dose, and it could cause a serious adverse event. So it's necessary for survival. There have been many, many studies done on outcomes, how well people do in healthcare environments and in healthcare situations. And one of the biggest predictors of poor outcome is some limitation in the ability to effectively communicate. So it's necessary for your health, good outcomes, and survival. It's also effective to help you adhere better to your therapy. If you understand why you're doing something, if you understand the reason for it, if you understand the science behind it or the benefits you're going to get out of it, you're more likely to adhere to that specific therapy. Oh, doctor, why should I take my disease-modifying therapy for my MS? Well, it's intended to reduce attacks. It's intended to reduce new MRI lesions. It's intended to reduce the chances that you'll have disability progression. Studies have shown that if you take your disease-modifying therapy, you're less likely to die than if you don't take disease-modifying therapy. So there's, that makes it solid and concrete for you. You have a reason for doing that. So that all is dependent upon effective communication. Doctor, why do I need to get this MRI? What good does it do to get an MRI? Well, let me communicate that to you. Let me show you through these pictures. Let me show you why we should do this study. It forges a relationship between you and your healthcare team. Communicating and talking to people establishes that connection. Communication is connection. Communication is caring. So what are some obstacles to effective communication? Let's think about that for a second. I'll just give you a few seconds. Think in your mind about what might be a barrier or an obstacle. I'm thinking of one big one, and it's been driving me crazy for the past 4 years, this obstacle to effective communication in clinic. What do you guys think? Any volunteers to shout out an obstacle?
Fear.
Fear. Okay, good. Anybody else? Time, yeah. Those are two good ones. An assistant? Having somebody with you to help you?
Not being able to get to the person because there's an assistant in the way.
Oh, somebody, a barrier in the way. There's a gatekeeper, a guard. Yeah, I have one of those. Yeah, it keeps me safe. That's good. Yeah, so there's some gatekeeper, a guard. Right, good. Physical and virtual. Yeah. So we got some of them. So we got time. We got a physical barrier or a bouncer. Maybe that's the word for it. We have a bouncer to keep you out of the club. Let's see, fear. Maybe some cognitive barriers. Maybe some trouble with memory and remembering the things that you need to communicate. Maybe trouble remembering the things that your healthcare provider communicated to you. Denial. I don't really have a problem. I'm not really sick. I don't want to talk about this problem. I'm going to, instead of the giraffe approach, I'm going to use the ostrich approach and put my head in the sand. Personality, so-called bedside manner, right? So if you don't gel with your doctor, if you don't find that there is that connection with your doctor, if you don't feel open in discussing things with your doctor, you might be embarrassed. There might be a sense of embarrassment about a certain problem. Language. How many people in here speak Spanish fluently? You got somebody. I don't speak Spanish fluently. It's hard. I'm trying to learn a little Spanish as it goes along. How many? You get free class? Good. All right. I might take you up on that. Yeah. How many people's doctors don't speak English as their primary language? That happens too. Especially as there's a physician shortage, and a lot of doctors are trained outside this country. They come to this country, and maybe in the hospital you see more doctors that may not have English as their primary language. They might have a thick accent, maybe difficult, so there can be a language barrier there. So let's look at some challenges specific to multiple sclerosis, because MS is a very, very unique disease. So MS affects many different functional systems in the body. So the visual system can be affected, walking can be affected, bowel, bladder, sexual function. There can be pain and sensory disturbance, energy levels. So as a neurologist or an MSologist, a physician has to be able to understand all of these different areas. Or if they need help with very specific areas, they have to bring in other members of the team to coordinate that care. So when you go for your doctor's visit, for your MS checkup, you may have many, many different symptoms and issues to address, and then we get into that factor of time, because usually your clinic appointments last, 15 minutes, half an hour. That's a lot of information to cover, a lot of body systems to cover in a short period of time. Now, one of the greatest pitfalls in treating multiple sclerosis is not recognizing that MS patients are allowed to have other medical problems other than MS, right? So if you come in with chest pain and the first thing that I think of is, maybe it's an MS symptom, maybe it's an MS hug, but I have to reel it back and think, well, this could be cardiac, it could be a heart attack, it could be a pulmonary embolism, it could be musculoskeletal chest, it could be something else. So that's challenging in and of itself. The MS doctor has to remember that MS patients are allowed to have other medical conditions. And you have to determine whether or not this is a neurological problem or some other problem. MS cognitive changes. Attention can be impaired. So you go with the idea that you want to discuss a certain part of your healthcare. You have a priority list, but when you get there, you think, oh man, what is it that I wanted to talk about? And you get distracted, like, oh, a squirrel, right? Difficulty with word finding, cog fog. You get to the doctor's office, it's taken you all morning to get ready, you've had to fight traffic, you've driven an hour to see the doctor from Port Charlotte to Naples, and you're exhausted by the time you get there. So there's that barrier, that limitation in the ability to communicate effectively because you're completely fatigued and exhausted. Medication certainly can impair your ability to communicate. A lot of MS medicines can have effects on cognition. So, who's on your team? You got a healthcare team for your MS, right? Okay. All right. Oh, my daughter again. She's an FSU fan. I don't know how this got in here, but some of you may not know that this Saturday, the Seminoles beat the Gators 31-13 at Bobby Bowden Field at Doak Campbell Stadium in Tallahassee, Florida. All right, here's the healthcare team. A lot of people on here. A lot of spokes in this wheel. Center is you. This is in no particular order, but I will point out that the neurologist is at 12 o'clock on top here. No particular order. The urologist is at 6 o'clock on the bottom here. But it depends on your symptoms and the types of problems you're having with your multiple sclerosis. So let's see, we have physical therapy, occupational therapy, speech, your support group, your care partners, husband, spouse, significant other, family members, the nurse, social worker. Some people go to a cancer center for infusions, so I included the oncologist there because they're part of the care team too, even though you might not see them every visit, but they're involved in getting your medications approved and making sure that the medications are safe for you to continue to receive. Psychology, pain management, let's see, the pharma, the pharmaceutical companies all have these layers of support that are built in for you to help you get your medicines, to get your medications paid for, that have nurses that staff call lines 24 hours a day, and they're very open and generous about this, and so you don't necessarily have to be on their medication to sign up for their services. It's another source of information, another person to communicate with, another system for you to communicate with. The pharmacist is there filling your prescriptions, looking out for things. Now, I hesitated to put this in, but I did anyway. Your insurance provider. They are on your team too. Even though they can be a barrier and they can be very difficult to communicate with, what we're finding is that with multiple sclerosis, they are there to help you get your medications, and they want you to take your medications, and they want you to adhere to it. Why? Because in the end, it saves money and it keeps you healthy. It's going to keep you out of the hospital getting IV steroids. It's going to keep you having fewer attacks. It's going to limit complications of the disease downstream. So they want you to adhere to those therapies, even though it's counterintuitive. These medications are expensive. They're paying a lot of money for you to be on them. But in the long run, they recognize that it's a cost savings because it keeps you healthier and safer longer. Let's see, anyone else that I should mention here? That's pretty good. That's your care team as I see it. But if you think about this, you have to communicate with each one of these. That's a lot of work for one person to do. Now, every one of these spokes here, these circles, they have to talk to each other too. They have to communicate somehow with each other. So imagine it's kind of like those flight paths that you see when you open up that brochure in the back of the airplane seat that shows everywhere that Delta flies, or everywhere. You can just see these sort of things that are all over the place. Or you can imagine a spider web sort of superimposed. My daughter should have put that on there as a graphic, but instead she was interested in giraffes. Okay, so practical tips to improve communication. Number one, ask. Speak up. In medical school and in teaching medical residents, I did tell them occasionally there were some dumb questions they shouldn't have asked. But when it comes to patient care, when it comes to you guys, there is no dumb question. It may be completely off base and wrong, and you may have asked it for the 50 millionth time, like, should I get my jugular veins ballooned, or should I take bee stings, or it's just completely ridiculous and off the wall. And I might get a little bit frustrated with it because we've talked about it before, but it is so important because it opens dialogue. It's okay to ask a question that may be completely off base. It shows that you've researched, it shows that you've done some homework, it shows that you're interested and you care. What worries me most is if a patient doesn't have any questions, or if they come in and they say, I'm fine, no problems, and they give that nonverbal cue that they look down and they're not engaging with me. There is a problem there. That person needs extra attention. They need better communication skills. I need to draw that out. But ask, talk, bring things up. Even if the question is wrong or based on wrong information, like Dr. Google, it opens up dialogue. Very, very key and important. Be prepared for your appointment. Do your homework. Know what you want to get. Know what your goals are out of the appointment. You guys are going to have a goal. You're going to have something you want to get out of that appointment. Some information. You want some symptom addressed specifically. I, as an MSologist, or your other healthcare providers, they have their agenda too. I want to make sure that you had your MRI done. I want to make sure your laboratory studies. I want to make sure that you're taking your medication. I have my agenda. Your agenda trumps my agenda most of the time. But know what you want to get out of that appointment. Prioritize your needs. Pick 1 to 3 things that you want to address. Organize it. Get it out there immediately, first thing during the appointment. There's something in medicine called the doorknob effect. Has anyone heard of that? That's the point at which the doctor stands up, they've concluded the visit, they walk out, they put their hand on the doorknob, they're about to leave the room, and that is the moment when the most important thing of the visit comes out. That's the point at which you guys say, this is what I really want to talk about. This is what I need from you, doctor. But in our minds, we've already closed the note, we've walked out, we're on to our next thing. We have phone calls to answer, we have emails to check, we've been up all night. So try to help us out and get that most important thing out first thing. It's hard, and I know it's asking a lot, but try to prioritize your needs, try to prioritize what you want to get out of that and address those. Have a checklist for things that needed to be done. I can't tell you the number of times people show up to their appointments, they were supposed to have their blood work done, they were supposed to have their MRI done, they didn't get it done, they come and the appointment is kind of, well, what do we do now? So have a checklist and make sure that you get all those things done. Do your homework, be prepared. This is a tool that's on the MS Views and News website. It's downloadable. It can be filled out online. This was developed by Dr. Steingo. Many of you have heard him talk before. Wonderful MSologist from the other coast. But it kind of helps you organize your visit. What are the 3 most important things? What are your medications? Have you had any exacerbations? When was your last MRI? So if you have trouble writing things down, you can type it in or fill it out online, except for the things that have to be circled, so you could print it out and maybe circle those later. Print's very small on this, but it's accessible through the website, so it's a very, very nice tool. Bring another set of eyes and ears with you. So commonly, when I see a new patient with MS and we make that diagnosis, I say, well, you have MS, and as soon as they hear those words, and many of you may remember this scenario yourselves, as soon as you hear those words, you completely shut down. You don't hear another thing that the doctor says after that. It kind of sounds like the teacher on the Peanuts. So it's like you have MS and you hear wah, 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 and you hear nothing else. So bring another set of eyes and another set of ears so you can go home and get a recap of what happened. So frequently I'll have patients come back a second time and they'll hear the news for a second time, and we're able to go over things in more detail, and it'll sink in. understand who does what on your team and ask the right team member. So when you come into the neurologist, don't ask them about your rash on your backside, because that's not really a neurological problem. So kind of figure out what the neurologist does. Likewise, don't talk to your internal medicine doctor about your specific neurological problems, because you might spend 5 or 10 minutes discussing a problem that I'm not able to handle, and I'm just going to say, well, you might want to bring up your blood pressure medicine to your blood pressure doctor and not to me, because I really don't want to interfere with that therapy. So understand who does what on your team. And sometimes that can be challenging because there's some overlap there. Slow your doctor down. We're in a hurry. You gotta slow us down. And there's some tricks to doing that. And there's some patients of mine that are masters of this. And they know how to slow me down. Come on in, doc. What took you so long? I've been waiting here a while. You look tired. You should sit down. You have a daughter, right? She goes to that university in South Carolina. How's she doing with, And then I'm a sucker. Then I'm in. I'm all yours from that moment on. So slow your doctor down. If you feel like your visit is going to require more time, call ahead and tell us that. Say, hey, look, I got a stack of forms for Dr. Baker. I know how much he loves forms. Can I schedule maybe a little more time so he can help me with these forms? Or I really have a lot to talk about. And someone who cares, someone who wants to communicate with you will do that for you. And I appreciate that, because I'll say, well, have them come in at 11:45, because I know I have lunch, and I don't really need to spend lunch with Jeff Kroll back there, because he's always bringing Moe's, or what's the other one? Tijuana Flats. I do love the ice from Tijuana Flat. Then I know that I can give that patient more time and attention, and it's not going to stress me out, and it's not going to put me behind, and it's not going to result in other patients having to wait longer, because then they're mad at me, and I don't like to be yelled at. Make every attempt to be earlier on time for your appointment. MS is challenging for a number of reasons, but getting to your appointment's hard, and I understand that. There's mobility issues. There's 2 handicap parking spots in the whole parking lot. There's a motorcycle in one of them. How does that happen? It's raining. The door doesn't open. There's no automatic door. So you get there, and you get there right at your appointment time, and then there's a line to check in. And so, and then of course my exam rooms are all the way in the back, so it takes 20 minutes to walk back there. And by then the appointment time's over, and then it really cuts into your ability to communicate your wants, needs, and desires. So, and most of the time when doctors are late, it's usually not because they're out on the golf course and they just wanted to hit a few more balls, or they were at the clubhouse or something. It's usually because there's been some hiccup in the schedule. Because a patient showed up late, or there was the doorknob effect and you had to sit back down and go through things again. So, we all have to be a little bit understanding, a little bit patient about that. Take notes during your doctor's appointment. Bring a pad, bring a pencil. Use your smartphone technology. There's certain applications that can help track your disease. Stuart, can I ask you, on the website, is there a link for MS-specific mobile apps at this point? No? Okay. Well, maybe I can submit a request later. I'd like to have a lecture just on mobile apps. Oh. That sounds good. Okay. If you can't communicate with your doctor, if you've tried and there's not that connection, there's not that caring, there's not that ability to interact or communicate, the best solution in my mind is get a new doctor. It's okay. We're a dime a dozen. You can find a doctor somewhere else that's going to satisfy your needs, that you're going to gel with, that you're going to get along with well. So that's probably the most practical point. If you go through 10 doctors and you can't communicate with any of those, you might have to look internally and say, hey, what's going on with me? So these are some MS-specific apps that I found. I just searched online. I Googled, MS mobile, multiple sclerosis mobile applications, and I found some of these. The MSA has a tracker. There's an MS Journal, MS Self. This is I think this is a Biogen app. All the companies have good apps that you can track your symptoms, track your progress. And so I think those can be, and they'll work on your iPad and on your Android or your iPhone. They can be very, very helpful. The nice thing about these cell phones is you don't have to type in or write. You can press that little microphone button and you can use the voice recognition. So, and a lot of these will summarize how things have been going for the past few months or since your last visit. So when you talk about MS symptoms, think about how long it's been going on, what's the duration, what's the frequency of the symptoms, what's the quality, what does it feel like, what makes it worse, what makes it better, what have you tried in the past. Sort of organize your thoughts that way so you can present that to the doctor. You can deliver it to them on a silver platter. It helps them efficiently and effectively assess your MS symptoms and come up with a treatment plan for that. So there's some other modes of communication, right? So there's smoke signals. Remember you doing this? Did you do this as kids? You get the cans and you put the string between them and make the telephones or the walkie-talkies. There's snail mail. You can communicate via snail mail. Your cell phone, texting. So there's some non-secure modes and some secure methods. So your health information is extremely, extremely sensitive, and it's extremely valuable. Does anyone have any idea why in the world someone would want your information about your health care? Any idea? I thought, why do they want to know about my hemorrhoids? It has no value. Why is someone going to steal my health information or try to get it from the cell towers? Well, it turns out that on the black market, a medical record can be sold for, and someone told me this, and I don't know the exact source of it, it can be sold for upwards of $17,000. So if they get your record, they can sell that for $17,000. Think about what's in that. Your family history, all your medications, insurance information, social security number, your address, your last known address, your health insurance information. Probably has your mother's maiden name in it. So your entire identity is wrapped up in that healthcare record, which is why it's so important to protect that information. So it upsets me when people get on Facebook and they post things about their healthcare and in a non-secure way, or when they contact me for a prescription renewal, they friend me on Facebook and send me an inbox message, "Hey doc, I need my Valium." That's not a secure method for communicating, but it's happened to me before. So those are non-secure, or maybe insecure, I don't know the right word for it. Email, text messaging, social media. So secure methods are your EHR patient portals, which ours, admittedly, in our practice, is terrible and cumbersome, and we're trying to improve it. But some doctors' offices have very beautiful patient portals where you can communicate with the doctors and nurses and get information about your laboratory tests and your MRIs very efficiently and very effectively. Secure fax, you know that fax is going right to the doctor's office so that it's secured, and anything that's there is going to be scanned into your record and then immediately shredded and destroyed. And then there are companies that come by that do all our shredding, and we pay them a lot of money per month to do this in order to protect your privacy and information. And a phone call, that's secure. Call the nurse, call me, and that's a secure method. So use social media socially. All right, so use your Twitter and your Snapchat and your Instagram and your Facebook and whatever else is popular today. I'm so old now, I don't know how all of this works. But use it socially, but don't use it for your healthcare information. And don't broadcast to the world things about specifically about your healthcare, because it's not secure, and it may make you vulnerable. Text messages are not secure, so avoid texting your information. If you want to text something to a provider very vaguely, hey, call me, I need to discuss something about my health, that's okay. But don't put your name or drug doses or other vital information. Here's my date of birth, here's my pharmacy number, this is a prescription I need. Don't text that to your healthcare provider, because it's going to be stored up in a cell tower, and people can get that information off of there. And plus, it's not documented in your chart. We can't keep track of those things and see what we did and what was called in, or how you responded to a certain medication. And despite all these modern advances, nothing substitutes for that interpersonal interaction in the clinic. You cannot practice medicine over the phone, over the email, via text. It's helpful sometimes to facilitate healthcare or speed it up, but and there are ways, and people in remote areas where they don't have access to physicians, you can do telemedicine, where there is a video screen and there's the ability to examine a patient remotely. But nothing substitutes for that interaction. And when I was thinking about the barriers or obstacles to healthcare, the one thing that drives me crazy is that darn computer that I have to type everything into and click, because I'm not looking at you or you or you. I don't have that because I miss things. I miss the facial expressions. I miss that eye blink that the giraffe does that says, hey, there's a lion around. I got to warn you here that something is happening to me that I can't verbalize to you. I don't have the words for it, but I have these nonverbal cues. So I think the computer in the doctor's office has been a limitation or a barrier to effective communication. That's my soapbox. So in summary, communication is necessary for survival. Effective communication with the healthcare team is vital to ensure good outcomes and reduce medical errors. So you're better off if you're able to effectively communicate with your healthcare team. There are many barriers to communication. Recognizing those barriers allows us to overcome those barriers. Giraffes are pretty awesome. Everyone agree with that? Yeah. I think so too, yeah. FSU beat UF this year, again, right? Ask. Open up your dialogue. Open it up. Talk to your doctor, ask, engage your healthcare provider. Care about them to communicate with them. They will care about you back in return and communicate with you. It's a two-way street. And we can start this process now. So with that, I'll open it up to any questions.
Everybody, let's give Dr. Baker a little bit of thanks here. Now we're going to start going into a little Q&A, okay?
I love that communication back to me, this nonverbal communication. The clapping is wonderful.
Great, thank you.
This is one of the most meaningful seminars I've been to. One, I'm going to Lion Country Friday with my grandkids, and you teach me how to communicate. I'm going to see you next week. That's
wonderful. Have a great, safe trip, and I hope you. Yeah, and good. Yeah, and maybe you'll be armed with some information on giraffes. And you'll give. Yeah, great.
Yeah. So, what do I do to get my doctor to read the note from the last time I saw him? Or her.
So your experience is you don't feel that the physician has done their homework. They haven't reviewed the information, because do you feel like it's just over and over the same thing?
Well, yeah.
Okay.
I mean, it's just, I'm telling her something that's going on with me, and she doesn't remember me saying it, or he doesn't remember me saying it.
So I think,
and I worked as a therapist, so I made notes, and
right.
I read the notes. I had to read the notes before I'd see the client.
All right.
But they don't seem. You guys don't seem like you read the notes.
Okay, I'm glad you. Yeah, so I do things a little bit differently. What I do is every one of my notes has all the information from all the notes before. So I copy over all the history from the last 20 visits, and then I put new history on top of that. So I don't have to read all the past notes. That note is all the past notes. So that's the way I do it, and that way I know what's happened I have a summary of what's happened for the past 5 years, and the way that I read is maybe different from the way other people read, but I read by paragraph. So I see it and I see the paragraph and it's in my head. I don't read word by word. But one thing might be to, at the end of your visit, ask for a copy of the note from that visit. And that's a subtle way of ensuring that the doctor has paid attention to that note, they've looked at it, and if they don't have it available at that time, if you ask for a copy of the note from the last visit, they will pull that up and print it for you. And that ensures that they have to somehow look at it, and maybe that will prompt them to register some of that information. That's a subtle way. But if you don't feel that the doctor knows you and knows your case, then, and it's been going on for a while, it might be time to, interview a new physician. So, but that would be a subtle way to do it. Say, hey, can I have a copy of the last note? And they say, oh, here it is. And they might skim it and look at it, and then it jogs their memory. But, yeah, so that would be my advice. Practical tip.
Hi, I believe Florida passed the legalizing marijuana. And how will that help with MS symptoms? And can you, like next year, when will that come effect to help with like pain in her leg and that kind of stuff?
That's a great question. So there was a review of the effectiveness of medical marijuana on MS symptoms and MS treatment, and there are certain symptoms that medical marijuana may be effective for. So, MS pain and spasticity and bladder dysfunction. Now, the trouble with all of these studies is that there's no kind of uniform type of medical marijuana. There's no standardization. And what we believe is that the medical marijuana, marijuana has, I think, 61 different components in it, and the one that we liked in high school was the THC that makes us high and gives us the munchies and the cotton mouth and things like that. I'm not talking from personal experience; it's just what I've read. And then I went to high school with Bridget; she knows better. And then there's the CBD, the cannabidiol, and that is the part of marijuana that may have its therapeutic benefits. And so right now in Florida, there's a little loophole because medical marijuana, or the CBD oil, is approved for people who have intractable epilepsy or severe spasms. And it's intended to be for those who have spasm disorders with an epileptic flare to it or with epilepsy. But that loophole currently allows for patients with MS who have severe spasms to receive CBD oil or the active medical component of it. So as this evolves, I think it's going to be a very important therapeutic option for people. And I don't think insurance is going to cover it, so that'll be a barrier. Stuart, do you have some more information on that?
The CBD gum is legal to be sold in the state of Florida, whether or not anybody has any medical condition. They could just contact a CBD company and get the CBD gum. Okay, so there is, now my understanding is that because you can buy hemp CBD type of products, but I'm not sure we know exactly how much CBD is in it and what the consistency of it is and that sort of. So I believe it's unlikely to be harmful. I think as the availability increases with the dispensaries open, I think it's going to be a good therapeutic option for people who have MS symptoms like severe pain and spasms in their legs in particular. And I've seen it work in patients who come from
places where it is legal, like California, Vermont, Colorado. They have homes there and homes here, and I see improvements objectively in their spasticity and leg symptoms with use of that. So I'm hopeful that, okay.
Now that they were talking about the medical marijuana, the components of the medical marijuana that's in it, it's not, of course, they say it's not what the regular marijuana is, the high. But what's in the medical marijuana, is that addicting or no?
Well, addiction is a very unique term. We have to understand what addiction means. There's a difference between addiction and dependence. So addiction is a behavior-based phenomenon where you seek out a medication or a drug or something else. It could be an addiction to gambling. You seek something out because it gives you pleasure and euphoria, and when you don't have that, you feel uncomfortable and anxious, and you withdraw from it. Physiological dependence is a change in your biochemistry due to repeated exposure to some sort of pharmaceutical agent. And so you can be physiologically dependent on a blood pressure medication such that when you stop it, you have physiologic changes, but you're not taking that blood pressure medicine to get a high or a euphoric effect or to feel better. So, I think that if you are taking a medication, whatever it is, to treat pain or a symptom, you're not taking it to feel high or have euphoria. So it's the concept of addiction doesn't apply. Now, there certainly could be a dependence on it, meaning that if you stop it abruptly, you are going to have some uncomfortable feelings afterward. And it's not necessarily a withdrawal per se, but you're uncomfortable. So that constitutes a dependence. So I think that it will have to, I don't really view like a CBD component as being an addictive process when it's used medically. Which I think is important to communicate, because many patients will decide not to take a medication because they fear addiction. So we use medications like Valium and clonazepam to help with spasms and increase muscle tone, but it has this connotation that it's addictive. But you're not taking it for a euphoric event or to get high. So that can be a barrier to adhering to therapy because of that fear of addiction. So it's not really an addictive process. Yes, ma'am.
I get spasms a lot in my toes. And the other night I had in my big toe, I mean, it was excruciating. When I couldn't get it down, I tried forcing it down. Would medical marijuana help me in that instance? And right then, because I take 4 Baclofen a day and it didn't help.
Yeah, so what you're describing is that you are having spasms in an extremity which is not responsive to traditional medical therapy with muscle relaxers. So that would be a situation where medical marijuana might be helpful. And then you might have to be on a dose that you would take routinely, but it certainly could be something that could be taken acutely if you couldn't get it to go away. But the studies on that, we need to do more studies on that, but that would certainly be a therapeutic option since it is legal.
So is there a difference between muscle spasms and muscle cramps?
So spasticity is defined as a resistance to passive movement. So the leg gets tight and it's hard to move, for someone else to move your leg or for you to move your leg manually. A cramp is a sudden contraction of a muscle. They actually exist on a continuum, and they're difficult to sort out. So a spasm may be the whole leg locks up. A cramp may be an isolated isolated contraction of like a calf muscle, but they exist along a continuum, and they're treated in a very similar way.
Question asked of me by somebody else recently along the same line was,
do spasms eventually lead, do multiple spasms? This person is getting leg spasms like every night in his or her sleep. Is that person wants to know if that will lead to spasticity?
Well, they're probably having spasms because there is an element of spasticity, but it could also be a sleep-related leg disorder too. It could be a movement disorder associated with sleep that is secondary to multiple sclerosis. So it probably needs to be teased out a little more.
Okay. Any questions around the room? Because I got a lot of them to ask him. Great.
Can you take medical marijuana with medical marijuana with your other medications?
I would answer that on an individual basis. I think you'd have to look at the whole collection of medications. And again, it's so new that we don't have a lot of experience with it.
I need more questions because this body needs exercise. Come on.
Is a progression of your symptoms, is that a sign that your therapy isn't working or the disease is just taking its course?
The easy answer is maybe both. So
without an exacerbation, without
right.
an exacerbation, just a slow
progression. Yeah, some of the medications are approved for slowing disability progression, but the problem with that is you don't know how much you would progress not on your medications. That's the $1 million question. But we do view disease progression as something that we need to address, and if it is significant, it does prompt the discussion or the dialogue about changing your therapy. Yeah. Number one, do you have the right diagnosis? Is this more of a progressive rather than an active disease? Do we need to switch medications? Is there, remember, disease activity like new MRI lesions lead to disability progression. So assessing MRI and whether or not there's disease activity can be important in making a decision to change or escalate therapy. But that's a complicated question, but a very good one. Yeah. Yes?
Are there any kind of markers now that are known to predict which medication is going to work best for which MS patient?
That's a good question also. So what you're asking is individualizing therapy based on biological markers. Not yet, but we can make some predictions about how aggressive a disease will be based on the number of attacks or relapses early on in the course of the disease and the number of MRI lesions that develop within the first year or two. So you can predict the aggressiveness of the disease such that you might predict a more aggressive therapy as a first-line treatment. So there are some markers that way, but you're really hitting the nail on the head there because that's what we need. You don't want to cycle through 5 different medications before you find the right one. And there are scientists now working on these biological arrays of things that they can look at to see which medication will fit that patient's disease state and fit their physiology such that they will be able to tolerate it better.
I didn't follow your answer because I'm not sure what a biological marker is.
So it would be like a blood test or maybe some spinal fluid that might show certain chemicals in the bloodstream, certain cytokines, which are inflammatory mediators in the bloodstream or in the spinal fluid, or maybe certain types of MRI scans that are non-traditional types of MRIs that you can use to choose the behavior of the MS or how the MS might respond to certain medications. Some people are looking at different bacteria in the gut, ratios of bacteria in the gut, looking at inflammatory markers there. So it's a whole new field of providing individualized, specialized medical care. And it doesn't just apply to MS, it applies to cancers and other disease states too.
Can you tell us anything about stem cell research or treatment and who it's suitable for, at what stage it's suitable for, and how you would go about that? Any information?
Yeah, so stem cells are, I kind of divide stem cells into what people really desire and want to hear about, and what they think the treatment constitutes, and what's really going on. So the stem cell treatment that you read about that, quote unquote, cures MS is really a form of bone marrow transplantation. So we know that MS is a immune-mediated disease. Our immune system is the problem, and unfortunately the nervous system is the target for it. And our immune system is present in multiple different organ sites in the body. These immune cells can be destroyed and then replaced. And so the stem cell treatment that we hear about is you take some of your own stem cells that can become anything, and then you culture them and you grow them in such a way that they can become your immune system again. And then you get some chemotherapy and you get some radiation therapy, and then you replace your immune system with your body's own stem cells, and then your immune system reconstitutes. But because MS was caused by that previous immune system, now you've rebooted it and you have a new immune system, and so the MS is no longer there. So because that's such an aggressive treatment, that's generally reserved for people who have really aggressive disease that have tried other medications. But we're trying to change our thought process. Wouldn't it be nice to be 20 years old, get diagnosed with MS, you've had one attack, and then you just take care of the disease and you do this procedure, and then it's done and over with, and you never have to worry about taking disease-modifying therapies, having attacks, getting MRIs again. So that's the paradigm shift there. That's what we're looking at. So that's a stem cell that is a here and now stem cell, but it's generally reserved for people who have not done well on other medical therapies. It's done in academic centers. It's done through clinical trials. Then there's stem cells where you've had MS for a while, you have neurological disabilities, and you want to get better. You want to improve, and those stem cell studies they involve taking those same mesenchymal stem cells, and you can't just really inject them back into the bloodstream, because how are they going to know where to go and what they're going to fix? You have to inject them into the nervous system again. So there was a pilot study done at the Tisch Institute in New York, and that showed that it was safe to do that sort of thing. So now they're working on developing protocols to study this stem cell further. Now there's other stem cells which take place in other parts of the country or outside of the country, where you go and you might get injections. There's a place out in California where you might go and you might get your own stem cells. You might get it injected into your bladder wall, into your tendons, into your muscles. So it doesn't really, in my mind, it doesn't really affect the actual disease process. And there's no data that shows that it works or that it helps. But people will go out there and they'll pay money to do this, and maybe they feel better, maybe they don't. I don't know. It's not through a controlled trial as I understand it. But those are the different types of stem cells. But I think what we're all looking for is something that is reparative and restorative, and we're not there yet, but we are in the process of setting up the trials to study that.
So speaking along that realm, with the new medication, well, it's not new, but with the medication that's been out for a couple of years now, Lemtrada, what is that doing as it's rebooting the immune system versus the stem cell therapy? It's
kind of similar. It's a similar concept. So with Lemtrada, the B cells and the T cells are very intimately involved in driving this process of attack on the myelin. So with Lemtrada, it's an antibody that binds to a certain cell surface molecule, and then the immune system that's there destroys the circulating T cells and B cells. So it gets rid of them all. The drug's out of your system within 30 days, can't be detected. After that, the immune system starts to repopulate. It's a reboot, really, and you get more of the B cells come back first, and the T cells come back, and then there's a certain ratio of regulatory T cells and regular T cells, and they talk to each other differently. So it offers that reset or that reboot. So it's a similar concept without the the chemotherapy and the radiation therapy and that sort of thing. So, now that we have that available, that is an option for patients to try before more aggressive therapies. But it's a similar concept, Stuart.
Stepping away from all of that, there are people that are here with MS and might be concerned that a family member might one day be diagnosed with MS. And what do you do to alleviate mental discomfort by a family when first diagnosing a new patient?
That's a very common question. So you get diagnosed with MS, and your first thought is, am I going to pass this on to my kids? And what is the risk of my child having MS? And the way that I do that is we do a little math problem. And we talk about the incidence of MS being 4 in 1,000 or so, and then we understand that because you're a first-degree relative, you're 20 times more likely to have MS. And that sounds like a high number, right? 20 times more likely to have MS than someone who doesn't have a first-degree relative. But when you multiply that 4 in 1,000 by 20, overwhelmingly, you're more likely not to have MS than to have MS. So there is some risk there. It's higher, but you're far more likely not to have MS than MS. So I just reassure them. And then I tell them if they have young kids, I say, let your kids get dirty and let their immune system develop, because I believe that exposure to viruses and bacteria and dirt and fungi and parasites, I think that confers some protection against the development of autoimmune disease or immune-mediated disease later on. So.
What is the status of a drug that is going to remyelinate?
So that again is another. There's a monoclonal antibody that was developed by a doctor at Mayo, and I think they're working, I want to say with Accorda on. And don't quote me on that, but they're working on developing the later phase clinical trials for remyelination. So that's it's forthcoming.
Speaking of a symptom or symptoms, many people are wondering why their doctors are not treating their symptoms right away rather than wait until it's so excruciating or so bad that then first being treated. What is your prognosis, or what is your thought on treating a symptom more quickly rather than waiting for it to be intolerable?
I just got this image of Barney Fife and Andy from when Barney said, "Nip it, just nip it." I think the more pain you have, the more likely you are to have more pain, and so you have to address symptoms as early as possible. Especially if you think about bladder symptoms. If you don't treat the bladder problems earlier on, then you have recurrent urinary tract infections. You develop drug-resistant bacteria. You can develop some renal dysfunction as a complication of that. Spasticity leads to more spasticity. The tendons get shorter. So early treatment, like with disease-modifying therapies, early treatment of symptoms is crucial. So.
What can you tell us about optic disturbances on people that are under 40 versus those that are over 40 and already having problems?
Optic disturbance?
Well, double vision. Double vision, blurred vision, things like that. Optic disturbances.
What do you, I mean, that's a...
How about eye pain?
Eye pain. Like as a symptom of MS?
Yes.
Well, eye pain can be a symptom of optic neuritis, and it can be a sign, or it can be a symptom that there's inflammation going on, so that can be a sign of an acute exacerbation. There are if you've had optic neuritis in the past, you can get a chronic eye pain that can be very, very difficult to treat. There's a condition called trigeminal neuralgia, which can be present in that area, and the trigeminal nerve innervates that area. So these are symptoms of MS. Eye pain can also be due to non-MS conditions, and so it could be glaucoma or an eye infection, and so it's important to have it evaluated. So.
With the stem cell procedure or the Lemaitre, whatever that,
Lemaitrata.
Does that, once you're finished that, does that alleviate some symptoms like balance issues or spasticity? Does that end when you're finished that process?
So with most MS treatments now, what you've lost you can't regain, and I'll say that with a star on there and a footnote. What we're finding is that with some of these medications, there's a certain subset of patients who actually, when you follow them long term, they'll actually have a meaningful improvement in their disability scale. So they will have something called a clinically definite improvement instead of a disability. And so it's changing again what our goals are for multiple sclerosis. There's a certain, maybe a third of patients will have an EDS improvement of 1 point or more, or at least remain stable over that period of time. So if there's ongoing inflammation and you get rid of that inflammation and you get rid of that tissue damage, it allows the nervous system to enter that process of healing. So.
More? No. Anybody else? Anybody else? Last chance? Nobody? Oh, we got one more, of course. Watch me run.
Did you talk at all about NEDA, N-E-D-A?
I kind of talked about that a little bit. We touched on that. So NEDA is no evidence of disease activity. I like to call it NADA. That's a Spanish word, isn't it? But that's no apparent disease activity, because some things we can't see. And there's our regular standard NEDA, which means no progression of disability, no new MRI lesions, and no exacerbations or attacks. And then we have NEDA or NADA 4, which adds brain atrophy, which is another way or another biomarker of measuring how successful we are with therapy. And that's our goal. We want no brain shrinkage, or we want to have our brain shrinkage be, because all of our brains shrink, we want it to be along the lines of our normal age-matched peers. We want no attacks. We want stable disease or stable ability, right? We don't want to have increasing disability, and we don't want to have any new MRI lesions. And so that's where we set our goal, understanding that we might not reach that goal, but if we shoot for that, we're better off than if we accept mediocrity in our MS treatment.
Anybody else? Great. Let's give Dr. Baker a round of applause.
Thank you so much, Stuart.
Thank you, thank you, thank you, thank you, thank you. Thanks for coming out today. And again, I want to thank everybody for being here, and of course for Dr. Baker's wonderful presentation. By the way, I forgot to tell you all, and again, I want to thank Sanofi-Genzyme and our sponsors that we're here tonight, because they all support what we do. And I want you all to thank Teva, Novartis, and we have, like I said, Sanofi-Genzyme and Bayer and Accorda, who left earlier. But I want you all to show them that you really appreciate them doing what they do to provide programs for all of you, and by them being here today. And so I thank you as well. Clap, clap, clap. Thank you very much. All right, with that being said, you all have a happy new year. Enjoy yourselves. Be safe, drive carefully. Extend yourselves to do things and not just sit back and wait for MS and what could be next, okay? Get out there and live your lives, okay? That's it. Thank you.